Thank you for coming, and hopefully there's a lot of people online as well. So just to introduce myself, I'm Dr. Peg Nopoulos. I'm from the University of Iowa. By the way, that's the cultural center of the universe, right? University of Iowa, yeah. It's not too far from here, yeah. I'm in psychiatry primarily, but I also do pediatrics and neurology. And this is the standard HDSA language, and in particular, to let you know that I have no disclosures. And today we're going to talk about juvenile Huntington's disease. I have an outline for you, because we're going to go over these topics. So genetics, the CAG repeat length, age of onset, prevalence, clinical features, and the diagnostic challenge. So how we're going to structure this today is I'm going to go ahead and go through the presentation, and then at the end I'll be happy to take questions, so please keep in your mind if you have questions come up. We have potentially some questions online as well. And so here we go, genetics. Now for those of you who were at the previous talks today, there was a little bit of this, but I think it's always important to start from the very basics so everyone understands what we mean when we say Huntington gene. So we take it all back to the introduction of the gene itself, not just Huntington, all genes. The genetic code is made up of DNA, and it's made up of nucleotides. And there's 4 letters, T, A, C, G. Amino acids are made up of combinations of 3 of those nucleotides. That's why that number 3 is important, because you hear triplet repeat or trinucleotide repeat. So those are some of the terms that you hear. But each one of those triplets make up an amino acid. An amino acid is strung together to make a protein. And the protein is what does all the work in the cell. So here's just a basic analogy. So the gene is a book. The nucleotide are letters. The amino acids are words. You string them together and you got sentences. So that's just an analogy to help you think about how genes are made. So the gene that causes Huntington's disease is called Huntington, and I know that always looks like a typo. It really is TIN. The disease is TON. The gene and the protein are TIN. And the acronym for that, or short name for that, is HTT. So in the Huntington gene, what we have is a repeat. Remember I said those trinucleotides that make up amino acids, and so you get repeats. In particular, in Huntington, it's CAG, which is the glutamine. You might also hear the term polyglutamine. So Dr. Catania mentioned this earlier, but it's really important that everyone knows that everyone has Huntington gene. It's a very important gene. It's probably very important for your brain development. So everyone has it, and everyone has repeats. So everybody in this room has a certain number of repeats. And in general, the normal repeats ranges from about 15 to 35. So HTT causes Huntington's disease only when the repeats are too long. So repeats of 40 and above cause Huntington's disease. And just one other name of naming that you'll probably hear sometime as well. So repeats below 40 are considered to be gene non-expanded. And repeats above 40 are considered to be gene expanded. Sometimes you'll hear the terminology positive and negative, which is a little bit hard to understand since everyone has a gene, so it's not a negative gene. So those who are non-gene expanded won't develop Huntington's. Those who have the gene expansion will develop Huntington's disease. So the age of onset and diagnosis is important because this is where the definition of JHD comes. So onset and diagnosis of HD is on average, if we take everybody with Huntington's, it's on average about 40 years of age. And I'll refer to that as AOHD, which is adult onset HD. Now, when the diagnosis of HD is made at the age of 21 or under, and that's not necessarily any magic to that number, but in general, we've defined it as 21 and over, we call that at that point juvenile Huntington's disease, or JHD. So about the repeat length and age of onset. So this is a pretty busy graph, but I'll walk you through it. So let's start on your right end where we have the 36 and 39. So that's the number of CAG repeats. And if you look above that, that's the age of onset in general. So those with 36 to 39, we call these sometimes intermediate repeat numbers. Those people are likely to develop Huntington's late in life. We call that late onset. I've had several patients I've diagnosed in the clinic in their 80s, and typically their CAG repeat is around 38. So adult onset in the next frame left of that is 40 to 49. These are all generalities, but that's where you would get most of the subjects who get Huntington's, because the average age for everybody is 40. And then earlier than that, if you were to manifest and get diagnosed between the ages of 20 and 30, that's relatively early onset. And then once again, below 21 is JHD. But I'm going to further divvy that up into adolescent onset and childhood onset. So adolescent onset would, of course, be during adolescence, so 15 to 21. And childhood onset would be at the age of 10 or less. So those are in relation to the CAG repeats, and you can see how the CAG repeats get longer and longer the earlier and earlier the diseases manifest. There's a little caveat in the bottom of the slide there. These are all estimates. Nobody can determine anything by just one number for any individual. And about half of JHD cases have CAG repeats that are less than 60. In general, we think about 60 and above as potentially someone who could get JHD, but that's not always the case. It's always an individual case by case. So how common is JHD? Well, the good news is that it's rare. So Huntington's disease itself is rare, and then JHD in particular is rare. So if we look at all of the HD patients, the best estimate is that out of all of the patients with HD, about 5 to 10% of them will be diagnosed before the age of 21 or diagnosed as JHD. And then it's even more rare for childhood onset. So this is just a graph that shows you the percentage of all JHD cases. So if you take all JHD cases, most of them are going to be adolescent onset. And then some will be younger, 10 to 15. And then, of course, the most rare will be those that develop it very early in life, 5 to 9. So genetic anticipation is a term that you may have heard. It's when the gene is passed on from a parent to a child, and there's a chance that it actually can get longer when it's passed on. So here's an example. That's just a visual. I'm sure you can count. There's more than 4 CAG repeats, but the example would be a parent who gets Huntington's disease because they have a CAG repeat of 43, so they're above that 40 threshold. But when they pass it on, their child has a longer repeat, 65. And now this is a repeat range that would potentially be in the JHD range. So that's called genetic anticipation. And this expansion is more likely to happen when the parent is male. So when males pass on the gene, there's more likely chance for anticipation than when a female passes it on. Now, it's really important to remember remember, these are just numbers. Most JHD cases come from fathers who pass it on, but the converse is that the vast majority of men with HD are not going to have a child with HD, right? It's not that every single man is going to have anticipation. The anticipation that gets long enough to create a JHD onset is not common. So it's important to think about how we word these numbers. So clinical features, what do we see in JHD? So like all forms of HD, like adult onset, Huntington's clusters in 3 main categories. So motor symptoms, cognitive symptoms or thinking skills, and behavioral symptoms. So we also have a common accompanying feature, which is seizures or epilepsy. So here's the names that we give the motor symptoms of JHD. And I tried to explain some of what they mean. So bradykinesia means slowing of movements. Rigidity is stiff muscles. Dystonia is muscles contracting in an abnormal position. Ataxia is a shuffled or unbalanced walk. Dysarthria is slurred speech. You can have a tremor. You can have a masked facies, which means that there's not a lot of animation to the face. And you can have chorea, which of course is the dance-like movements. The thing that's different is that for JHD, a lot of the symptoms are referred to as Parkinsonian, right? So if you heard that term before, so masked facies, tremor, stiffness, slowness, those are the motor symptoms that are typical for persons with JHD. They're atypical for people with adult onset HD. So as you know, people with adult onset HD have chorea. In general, we can classify that those with a lot of chorea or involuntary movements, they have a hyperkinetic motor symptom. JHD typically has a hypokinetic, meaning that their movements are slower, they're stiffer, more Parkinsonian. So that's one of the biggest differences in terms of the clinical symptoms between adult onset and JHD. Now, chorea can happen in JHD, and bradykinesia and hypokinesis can happen in adults. There's crossover, but these are just generalities. So the cognitive symptoms are the thinking skills, everything from general intelligence or IQ to specific functions like memory, attention, language, everything's affected. For children with the childhood onset before the age of 10, it may be a failure of thinking skills development, right? So if it's hitting you very young, then you might not have the chance to actually learn the skills that you would if you didn't have the disease. And sometimes for JHD, it's often seen as a declining school or academic performance. So that's an indicator of cognitive problems. And then like adult onset, these thinking skills progress over time. So once you start seeing them, they will progress along with the disease. So behavior, psychiatric symptoms. So behavior can be divided into two main categories. What we see is externalizing behaviors. So that's behavior that you can observe. And it's hyperactivity, inattention, opposition, which is not wanting to follow the rules no matter what, talking back, aggression. And then internalizing behaviors are what people feel inside. So in order to understand what an internalizing behavior is, you have to ask them, how are you feeling? So those things are being sad or depressed or anxious or obsessions, because those are things that people can't see from the outside, but you can feel from the inside. So externalizing and internalizing behaviors. For JHD, the most common symptom is externalizing. So ADHD may be diagnosed before JHD is diagnosed. Aggression may come on quickly with no clear triggers, and sometimes can be quite severe. But in general, the externalizing behaviors are typically the things, the type of behaviors that we see in JHD. So this is just one study of presenting symptoms. So that means the symptoms that parents and care providers first see. So what is it that you first saw that you thought might be related to Huntington's? Well, most of them started out with some behavior symptoms. About half of them started with some motor symptoms, and then a smaller percent started with the thinking problems. But during the course of the disease, the number of cases that experience behavioral disturbances is quite a bit. So even if it doesn't present with the disease, behavioral disturbance is often a big issue. There's a lot of reason for behavioral disturbance in these children. So seizures, that's another accompanying feature. Up to 30 to 40% of cases. And there's different flavors of seizures. I don't think they're in your handout. I don't think we need to go over them here. But they tend to be more common in the earlier onset cases. So typically the children who are diagnosed 12 or below, they are more likely to have the seizures. You can get them at any time. It's pretty rare to have seizures in adult onset, but in JHD, it's most common with the childhood onset. So not too long ago, last year, we conducted a survey. Actually, this was based on conversation that I had with some people who were JHD families. And in this age of social media, a lot of the families will communicate on a regular basis through these websites. And in general, we got a feeling from the community that there were symptoms that patients were experiencing, but that was nowhere in the literature, and the physicians weren't all of that familiar with them, and we decided to get a sense of what these were and how common they were. So these are the symptoms that we identified: sleep disturbance, pain, itching, which is in quotation marks, so I'll talk about that more, tics, and then psychosis, which is hallucinations and delusions. So we sent out a web-based survey on those sites that I'd mentioned, Facebook and others, and then the parents or the caregiver filled out that survey. And so here we got 33 responses, which is a lot. That's the only way you can do it is to have, the social media and those websites. That was helpful. And the average age of diagnosis was 12. At the time that the parent was filling it out, the average age was about 15. And of course, the CAG repeat was very wide. But this is a good example of the things that I was mentioning to you before. So on the left-hand side, what we call the Y or the vertical axis, you have age of onset. And then on the bottom, you have CAG repeats. And so you see the longer the CAG repeat, the earlier the age of onset. But you can also see, too, that these are all subjects who've been diagnosed with JHD, and some of them have repeats that are between 40 and 60. So I think that's just actually a good example of the things I was mentioning before. So it was a big sample, and the prevalence of these symptoms really was shocking to us. So out of all of those families that were surveyed, over 90% of them, or close to 90%, said that their child with JHD had sleep disturbance. Tics at a lower percentage, but still very high. Pain, itching, and psychosis, all very common, much more common than we had anticipated. And just a little bit more about that. So almost 90% of caregivers said that their child had sleep disturbance. And this was all kinds of sleep disturbance. So initial, which means trouble getting to sleep. Middle, which means waking up in the middle of the night. Or terminal, waking up early in the morning. So all sorts. And 10% reported night terrors associated with the sleep disturbance. So tics are important. They're a motor symptom, so they're kind of the classic symptoms, but they're different than involuntary movements because tics are blinking, sniffing, so they're very quick movements. They can be with the head, they can be a vocal tic. But the blinking and sniffing were actually the most common tics that people saw. Pain was something that was really something that plagued a lot of our patients and then therefore plagued their caregivers. The legs were the most common site of pain. And then itching, remember I put that in quotes, and the reason for that is because this is a phenomenon that's not associated with a rash. So there's nothing on the skin that makes it look like the patient is itching, but they have the sensation of itching, and it can be extremely uncomfortable, and it can come and go. And here's a little bit more about how severe those symptoms are. So if you just look at sleeping, nearly half of those parents said that the sleeping problem was not only present, but it was severe. For tics, most of them were mild. For pain, 50% of them said that this was moderate. So these are not minor things. Itching, severe about 40% of the time. And psychosis is something that's actually somewhat internalizing. Sometimes it's hard to know when someone's having hallucinations or delusions, but those in general were qualified as mild. And then the frequency of these symptoms were also very common. So with the sleep, you saw that 68% of those parents said, not only does my child with JHD have a sleeping problem, but it's every night, every single night. Some of them say come and go. Some of them say less than that. But once again, I think there's many symptoms of JHD that are under-recognized but quite common. As I'd mentioned, the survey was a little eye-opening to us. And so we're trying to publish this paper, and I think it's going to be a really helpful thing for communities to to disperse, and in particular to the physicians who are taking care of the children with JHD, because it's not something that there's a lot of care guidelines for. So it's important to bring light to some of these symptoms. So duration of disease. This is somewhat controversial because it seems like if you have an earlier age of onset, you should have a faster course. But that's not the case. When we look at this, when we look at all the numbers, when we look at the cases, and remember, everyone's individual. But in general, the duration of JHD does not seem to be any different than the duration of adult onset disease. And in general, that is 15 to 20 years from diagnosis to death. It's pretty much the same. Now, even though I told you that the CAG repeats can dictate when the disease starts, it doesn't tell you how fast it's going to be. And once again, it's a little bit, I think those of us who take care of patients with HD, seems like the ones who have the earliest onset may progress a little more quickly, but it is all variable, and there's plenty of patients who have an extended course, 10 to 15 years, just like AOHD. So the diagnostic challenge, this is no minor thing, and it's one of the reasons probably why the title of this seminar was specific to that, because diagnosing JHD is not easy. It's not easy for families. So this is important. How is the diagnosis of JHD made? It is one thing and one thing only, and that is when you have a neurologist or a pediatrician identify unmistakable, which means not subtle, neurologic or motor signs. So the diagnosis is based on motor abnormality, okay? But what we know is that's challenging because there's a lot of symptoms that happen way before motor abnormalities, right? So the challenge is that parents will say, I've had problems with behavior and thinking for years before motor onset. And it's often, too, it's just difficult sometimes to get experts to be able to see children. And once again, it's just rare. Even an HD expert may not be that expert in seeing JHD. So the average length of time from what parents say is the first symptom onset to diagnosis is 9 years, which for children is just way too long. And it's a horrible time for families. It's a horrible time, especially because the most common presenting symptom is behavior. And remember, oftentimes the behavior and the thinking skills can predate the motor symptoms, sometimes by many years. So let me tell you a little bit about the Kids HD program and who is eligible. So for the Kids HD program at the University of Iowa, subjects are young adults, ages 6 to 25 years, who are at risk for Huntington. So they have a parent or a grandparent with Huntington's, and they currently don't have any symptoms of Huntington's. And then for research purposes only, we get DNA. And then we're able to divide those children into two groups. So the children who don't have the gene expanded, GNE, they're not going to get Huntington's disease when they grow up. And those who are gene expanded, GE. So those are children who will later in life develop Huntington's disease. At the time we're seeing them, they're not having any symptoms. And then we also have a JHD program, which is specific to children who have already gotten the diagnosis. And subjects who are, again, 6 to 25 years of age who have already been diagnosed are eligible for that. But that's a study, once again, for those of you who missed it at the beginning, the introduction was, I'm from the University of Iowa, which is otherwise known as the cultural center of the universe. It's an awesome place, and you get to travel. Hopefully not in the middle of winter, but even if you come in the middle of winter, you get to come to Iowa City, Iowa. Yay. Whee! So in what we do, this is an observational study. So what we do is we get a brain scan, which looks at brain regions. This is brain structure. In particular, the regions of the brain that we're interested in for Huntington's is the caudate and the putamen. Those are the colored pictures that you see there. And we look at brain function by looking at tasks like thinking, concentration, and also motor. And when we look at behavior, remember I told you that most of kids with JHD will present with behavior. And when I first started in this business, in Huntington's, I've been a psychiatrist for a long time, but for Huntington's disease, it's been about 15 years for me. because I'm a psychiatrist, I thought, I'm pretty sure that behavior is going to be the key to diagnosing JHD. We can do it earlier. But I look at my own data, and I see that's just not true. So what you see here is we get from those kids who come who are at risk. This is not the JHD kids. These are children who are at risk. And we ask their parents to fill out rating scales. And parents actually are really good at quantifying and defining what their kid's behavior is. They're really good at it. And so aggression and opposition is AO, hyperactivity and attention is HI on the graph, depression, anxiety is DA. And then I divided these up. So the blue bar is is children who are gene non-expanded. So remember, the blue bar is children who are not going to develop Huntington's. They do not have the gene. They don't have the mutation. But the ones who do have the gene, I split up into two groups. One of them was gene expanded, but the CAG repeat was somewhat short, 40 to 49. And then the other children were also gene expanded, but they had a much higher repeat, so they had 50 to 73. And once again, these are children before they've had the onset of the disease. And you can see here, just looking at the first category, AO, that there's really not much of a difference between those three groups. So it's not necessarily in terms of aggression and opposition. It's not just the children who have the gene expansion. It's also the kids who don't have the gene expansion. And then same thing for hyperactivity. And the only thing that was actually distinguished between the groups, which is a little bit shocking and interesting, I didn't anticipate this, is that the gene negative children, the kids with the non-expansion, are more likely to have depressive symptoms than the kids who had the expansion. So this was really the reverse of what I expected, right? I expected that the children with the gene expansion may have far more behavioral. And I think the summary of this is that behavioral abnormalities in children can come from a lot of different things. So as a psychiatrist, I know mental illness is really, really common. And there's a lot of reasons for children to have behavioral disturbance, in particular in the environments that they may be living with in a Huntington's family. And so whether you have the gene or not is not differentiating whether you have significant behavior problems. So behavior is a non-specific finding. It's not specific to kids who have the JHD gene or the HD gene. So that's the diagnostic challenge. I'm going to pause and ask a question from the audience. I said I was actually going to ask them at the end, but let's go. You go ahead, ask me.
Just curious about how many of your subjects were sisters and brothers of ones that weren't going to get HD, of ones that were going to get it, and whether anxiety and depression has to do with the guilt that they have, or on the fact that their brother or sister maybe then showing signs are going to get
Yeah. That's an excellent question. I'm going to repeat it. So the question was whether or not in the sample I had siblings of at risk and siblings where one was gene negative and one was gene positive, and the one who was gene negative might feel guilty. Now, in this sample, nobody knows what their gene status is. These are all children at risk. Their gene status is for research purposes only, and so the siblings don't know. Do I have it? Do you have it? So there's no knowledge, because for that study right there, it was the children at risk. But it's a good question. So the diagnostic challenge is that there's one thing that defines the diagnosis, which is motor, but you get a lot of behavioral and cognitive symptoms prior to that. And what happens is a lot of families, rightly so, they want to know. Of course they want to know. Families want to know, and families don't want to wait, especially if they know, if they worry that there's thinking skills, if they worry that there's behavioral problems, if they worry that they have minor subtle motor things. Remember, the neurologist is really going to wait until they're certain that it's motor things. But if moms and dads are really good at sniffing these things out, because they know their child, if they think that something's happening, it sometimes takes a long time to convince the neurologist to go ahead and get that gene test. But here's what the neurologist will tell you, that that's risky. So the risk of getting a genetic test based on a non-specific finding, like behavior, is that that symptom won't be related to HD. That's the risk. So here's an example. So you have a child, 15 years of age, with behavior problems. No motor signs. Maybe some subtle motor signs, but nothing significant that the neurologist is going to say is relevant. And because of those behaviors, the neurologist goes ahead and gets the test. And the CAG repeat is 43. Now remember, there's no motor symptoms, so this child has not yet had onset. That probably means, with the CAG of 43, that that child is not JHD. That probably means that that child is going to get motor symptoms and is going to develop Huntington's as an adult. Not as a 15-year-old, but likely as an adult. So it's not JHD, but it could be interpreted by some people as JHD. So this child now knows that they are gene positive. This child now, who's 15, very vulnerable in terms of adolescence and emotions and everything that's going on around them. And they didn't have the chance to have a say, because they're 15, whether or not to get that test or not. So JHD is not diagnosed on behavioral symptoms because they're nonspecific and because the neurologist absolutely wants to avoid this scenario, wants to avoid the scenario of getting a repeat that's in the adult range but does not explain the behaviors. So, what can we do to help the diagnostic challenge? Well, how about imaging? That's what we do in the Kids HD study. We do imaging. How can that help? So one question is, can MRI help the diagnosis of JHD? So one thing that's important, a really important distinction, is that when you go to a doctor and get an MRI scan, it's read by a radiologist, and it's what we call qualitative assessment. They look at it. They look at it, and based on their visual interpretation, they'll say that's an abnormal brain or a normal brain. Okay? So this is a picture of 5, they happen to be 5-year-old girls. Not sure, they're 7-year-old girls. And this is a picture, we call this a coronal cut, because you think about a crown, but you cut here and pull the face off, and if you're looking at the scan, it's looking into the face. And you don't need to know anything necessarily about brain structure just to try to compare those. They actually look pretty much the same. And I don't know if anyone wants to vote for one or the other, but I can tell you for my purposes it's hard to distinguish those. But the one that has JHD is number 4. And not only does she have JHD, she has childhood onset JHD. She has a CAG of 101. And she is really severely ill. And her brain scan, qualitatively, doesn't look that much different. So a clinical scan from a physician is not going to be helpful for diagnosis. Now, what about quantitative MRI? So remember, from a clinician, qualitative means looking at it. Quantitative is something we do only in research at this point. But what we do is we get the scan, and then we have software that gives us numbers. So it measures things. So we get numbers. We get numbers of the volume of regions. And the regions that we're really interested in, we're interested in everything, but in particular, we're interested in the caudate and the putamen. So this graph here that I'm showing, these are all normalized so that the 0 point on the vertical axis, that's representative of where the healthy controls are. So these are, this is one JHD case, and it's compared to 7 matched females, and they're all healthy controls. So the 0 bar is where the healthy control volumes are. The red bars, if they're lower than 0, that means they're smaller than the controls. If they're increased above 0, that means they're larger than controls. All of these are lower than controls. And in particular, the areas of the brain that we know are affected primarily by Huntington's, the caudate and the putamen, are very low, very low. So low that they would be clearly considered to be abnormal, even though qualitatively it may look okay. So potentially, quantitative MRI could be a tool by which we might be able to assist the neurologist in being able to determine when to diagnose. These are things that we're working on. It's still not necessarily coming soon, but things that we're working on with these types of studies. So a clinical scan is not going to be helpful, but a research scan. It isn't proven, so it's not available yet. So once again, the diagnostic challenge. Is there harm in delaying diagnosis? So the one thing I didn't put down in here is that, yeah, it's horrible for families. It's horrible. That delay, that worry, that knowledge that you kind of know, but no one else is helping you along. Everyone else thinks you're wrong. It's horrible. For the child, there's nothing that's harming them, meaning that there's no current treatments that are going to change the course of the disease. So a delay in diagnosis is, at this point, not delaying anything that the child would have an opportunity, right? So this may change in the future with gene therapy, but right now, the child is not missing out on something by having a delay in their diagnosis. The medications that we use to treat the behavioral symptoms are not any different than we use to treat other children who don't have HD. So it's stimulants for attention deficits, lots of different medications for other behavioral symptomatology. There is one question about whether or not stimulant medication can potentially advance the disease or make the disease worse. It's a theoretical risk. And what I mean by that is stimulants, in general, release a chemical in your brain called dopamine. And dopamine is one chemical that's important for movement. A side effect of stimulants is tics and movements. So there's this question of whether or not, in a movement disorder, if you give someone a stimulant, will it make it worse? But there's no clear evidence to support it. And remember, in JHD, there's not hyperkinesis, there's hypokinesis. So once again, there's no clear evidence. And in general, for the people that I take care of, I give them a choice. I let them know it's a theoretical risk. But in particular, if that stimulant is helping them think, and they're really doing good when they're on it, then they should stay on it. So is there harm in giving the diagnosis of adult onset disease to a child who did not have a say in whether or not they want that information? Yeah. So a child who is, once again, that example, 15, have behavior problems, went ahead because parents wanted it, got the CAG repeat, and now it's something that's hanging over their head, and they didn't necessarily want to have that. They didn't make that choice. So knowing whether or not you want to live with the knowledge of your gene status is something that most people, importantly, take very personally. It's a very personal choice. I'm preaching to the choir here. All of you know this. And in particular, for all the people at risk, very few people, right? Only 5 to 10% of people actually go through with getting pre-symptomatic testing. So it's a very heavy burden to live with if you are gene positive. And for a very young person in adolescence, then that can be really quite disruptive. So those are the things that make us pause whenever we make a decision about getting that diagnostic test on a young person. So I just want to thank everybody in my lab. So, and in particular, if you see Jordan, who's the tallest person here, and Jennifer, who are actually sitting out today and yesterday and the day before on the Kids HD and JHD table, they've been really helpful for that. And most importantly, our program has been running for many, many years. And a huge thank you to all the kids and the young adults who participated in our program. So, questions? Great question. So I'm going to repeat that. So for the people who are streaming. So you're a young woman whose husband was recently given the diagnosis of Huntington's. She has young kids, 3 and 10 months. Is that what you said? So very young. Yeah, very young children. The question is, when is a good time to talk to your children about Huntington's? So once again, it's very personal. Each family is different. In general, the earlier the better. most important thing is that children sense what's going on. Children are really smart. And they can sense when things are wrong. And when parents aren't talking about it, they get confused. They may blame themselves. If they're old enough, they may go to the internet and see some things that are not inappropriate at all. So it's different for every family, and it's different for every child. I've had parents tell me that they have one child that they know wouldn't handle the information very well. So they wanted to handle that differently. They wanted to do it differently than the child that they knew would handle it better. So it's individualistic. But the earlier you can do it, the better, because knowledge is power. And it's best coming from you. It's really best. And some of that means that it's age appropriate. So when they're 6 or they're 7, they may not completely understand what it means about them being at risk. They may understand that dad has Huntington's. But their understanding of what that means for them is probably pretty immature at that time. Way different for a 13-year-old, right? And so talking to your child about Huntington's is going to be age appropriate. When they're very young, you use very general terms, and they may not truly understand what that means. When they're older, they'll know exactly what that means. Another question?
If I could just piggyback on that, there's a great book written by called Talking to Kids About HD. So if you look that up, you can find it on Amazon or wherever. She's a social worker for the Huntington's disease program that I worked with my husband, and I used the book for my girls. Talking to kids about Huntington's disease.
Awesome. So we have a resource. I'm going to say that out loud. So it's Talking to Kids About HD. It's by Bonnie. What's her last name? Hennig. Hennig. Bonnie Hennig. And she's from UConn, from the Center of Excellence there. And it's got rave reviews by the people who use it. So talking to your children. So it's a great resource. The HDSA also has on their website pamphlets as well. And once again, I think the most important thing is, as parents, you'll know. You're going to be the best judge. You're going to talk to other people, maybe even other HD families, and they'll tell you their experience. But you aren't them. Even if you're in the same boat in being an HD family, you're going to know best what's best for your child. Other questions?
Just a comment. Thank you very much, Dr. Nopoulos. About the behavioral thing, I talked to a neurologist, within the last 15, 20 years since I've been involved, and the child showed behavioral and emotional signs of Huntington's disease. They didn't have Huntington's disease, basically mimicking his environment. So that was, yeah, what you said, you don't
Mm-hmm.
because everybody asked me, well, why did they get tested when they were younger? Because, why do you want to live that way?
Right. So the comment was about the fact that that behavior sometimes is not specific to HD, and so that shouldn't be the reason why you get testing. And behavior, the other thing that's important is that when we think about the disease process, so when we say that length of disease is 15 to 20 years, that means from motor onset. Okay? If you want to include the symptoms that you had way before, you can, because, by the way, many of those are certainly related to HD. They may very well be changes in the brain that are related to Huntington's. Don't get me wrong about that. It's just that the disease process and progression starts with motor onset. Sometimes, and this is true definitely for adult onset too, you can have behavioral symptoms way before you have motor symptoms, and they may come and go. They may come and go. And so the thing that defines the disease progression process is the onset of motor symptoms. That's why when you have behavior, sometimes you can have difficult behavior for years and years. And it doesn't mean the diagnosis is missed. It means the disease process that defines progression hasn't started yet.
It was like with my daughter, she was diagnosed at 20 because of an abnormal gait. Looking back over her records, they figured she really probably became symptomatic around the age of 15 when there was a lot of behavior issues where I thought, she's 15, you know, she's a monster child. But she actually wasn't diagnosed until she was.
Right. So the comment was a daughter who was diagnosed at 20 with motor symptoms, a gait abnormality. But looking back, the physicians reviewed and thought that onset was probably in the teenage years, 15, because of behavior. And the comment about being 15 is, okay, it's its own psychiatric illness itself, right? Adolescence, whoa, yeah. And girls, yes. Boys too. But the brain does not completely develop until the age of 30, mid-20s. For don't look at him that way. For women, it happens a little quicker than men. So we all know this in general, right? Because, girls mature faster than boys. So same thing in the body as it is in the brain. So about in the mid-20s, late 20s, that's when girls finally have full maturation of the brain. Boys are a little bit behind that. But the time that's really dynamic is the teenage years. And we know this from looking at brains. We know this from studying brains. So normally, the piece of your brain that's called the cortex, which is the bark, which is where all your brain cells are, that's undergoing what we call pruning. So it's cutting. So normal development is that you have all these connections, all these brain cells talking. But in adolescence, we have to cut the ones that we don't need and keep the ones where we should. It's a normal developmental process. But it results in a very significant drop in the volume of your brain. If you look at those slopes, that's called this mighty slippery slope of adolescence. It's a very tumultuous time for the brain. And so it's really hard to know, is this teenage years? Is this the beginning of JHD? Is this him or her acting out because their dad's sick? Lots of reasons. So it's really hard to interpret.
Question about drug interactions. A lot of kids who have behavioral problems get put on different drugs because they think they're hyperactive, any number of things. Has there been any research to show triggers for certain drugs for JHD, and would that then be a reason to want to have your child diagnosed early because then you could avoid those trigger drugs?
So the question is, because of the behavioral problems, lots of kids with JHD are on psychiatric medications. And the question is there any drugs that potentially could interact or trigger with the disease that you would need to know about if your child had JHD so you could avoid it? And the answer is no. The answer is no. The big caveat to that is, oh my goodness, we haven't studied that. There's very few patients. I mean, we're starting to gather quite a bit of information, but it's still very small amounts of information. But I'll go back to the example, probably the best example is the stimulants. So the stimulants, and those are the ones that are used the most for inattention, and so that's something that a lot of kids who are later diagnosed with JHD, they get the diagnosis of ADHD, and they're put on a stimulant, Ritalin, Adderall. Theoretically, because it works on the regions of the brain and the chemicals of the brain that govern motor symptoms, theoretically, that could possibly make disease worse. But we say that theoretically because we don't know. And as a matter of fact, I have a lot of patients who are adults who are pre-symptomatic, but they're on Ritalin. And again, what I tell them is, theoretically, this could make things worse. But if this is really important for you, why don't you try it off of it and see if you do okay. If you really need this drug, then go for it. Right now, there really isn't any evidence, and I can just tell you kind of anecdotally that I haven't really seen anything that made me think, we started that drug and it really seemed to progress things. I haven't been able to pinpoint any of that. So I think the answer is no. There does not seem to be any medication that has an interaction with the disease or can somehow hasten it.
One thing that I've kicked around as far as what age do you approach it with a kid is, obviously, not 6, 7, 8-ish type of, but they get to 15, 16,
Mm-hmm.
Now you've got kind of a cascading effect there. Well, maybe the kid has it, maybe he or she doesn't. Well, now they're acting out behaviors that are possibly, sometimes pregnancy is unintended. I mean, isn't that the time to really zero in on, are you carrying this or are you not?
Yeah.
Because you can also perpetuate into yet another generation.
Sure. So the question is the question about, once again, adolescence and behavior, and adolescent behavior, which is exploring with sex and getting pregnant. And those are all, vulnerable times. And it's what I call the retrospectoscope. So looking back, it always looks crystal clear. I should have done that. It's never that way. Life is never that easy. And so it's certainly good to think about being able to identify something early enough so that you can prevent an unwanted pregnancy. But in reality, no, it's really hard. Like I said, if you have not had a motor onset, then you don't know. And once again, if it's a child that doesn't really want to live with that knowledge to get testing. So kind of the devil's in the detail about things, and it sure would be nice if we could prevent those things, but once again, it's sometimes life doesn't happen that way. Sometimes it's just not that easy. And it's a diagnostic challenge. That's the title of the talk.
You said this earlier, I apologize, but is there a tie to severity of behavior and the number of repeats? And also, could you say a little bit more about the aggression that can come on without any clear triggers? And I'm thinking about another boy where it was literally like a switch.
Yep.
One school normal, first 2-3 years of school very normal, and then literally like a switch to the point where very bizarre behaviors.
So let me address the first question, which was, is there a relationship between length of repeat and behaviors? And we haven't really seen that. On my graphs, remember, I took the kids who were pre-JHD, right? The ones that had they were not yet sick, but they had a repeat of 50 to 73, which means depending on what age they were, they may develop it soon. They tended to have a little bit more. It was just not dramatic. So there does not seem to be a relationship between CAG repeat and behavior, from what we can tell now. And then the second question was kind of characterization of the aggression. And it's not necessarily different than what I see in all my adult onset patients, which is that it can very much be hair trigger. And sometimes I liken it to seizures because it comes on 0 to 60. They're angry, they're in a rage, and you cannot reach them, right? You cannot get there. And it's like a seizure, like when you're having a seizure, stop having a seizure. No, they can't stop having a seizure. And then oftentimes it's a quick offset.
Well, I know there are other mental illnesses, childhood mental illnesses that have some of that characteristic. Is this possibly something that sets?
So is there other mental illnesses that could mimic that kind of behavior? I must say that kind of quick switch is common in Huntington's, but probably the most important thing in the context of a child's life and in context of a child with potentially with JHD is that change in behavior, right? So oftentimes behaviors are pretty stable. So the hyperactive or aggressive child is hyperactive or aggressive since they were little. And oftentimes it's, like you said, kind of a night and day. It's a major switch in behavior that potentially could be a light bulb of, this, and especially if it's somebody at risk. Now, you bet it could potentially be other things. It could potentially be acting out. It could potentially be anxiety. It could potentially be psychosis, which is very, very rare in someone who's young. So it can mimic other things. And once again, even though I qualify the fact that that kind of aggression, to me, seems really classic for JHD, it's still not something that I would be able to say, there's that, I see that pattern, I've seen that before, I know for sure, or let's get the test. It's still just non-specific. There's another question.
So, how common is it for an adult, when the onset when they're adult, how common is it for them to have like severe behaviors as an adolescent?
So how common for adult onset, how common is it for them to have had severe behavior in adolescence? Did I get the question right? Very common. So once again, this is the same disease. JHD, adult onset disease, it's the same disease. You think of it on a spectrum. And so many of the symptoms and so many of the patterns of symptoms are similar. So just like JHD, for adult onset HD, it's very common to have behavioral symptoms that precede the motor symptoms by years and years. So it is very common. Now, it's also the same thing. We don't diagnose adults with Huntington's based on their behavior because it's nonspecific. Sometimes it can last for years and years and years before motor onset. Sometimes it comes and goes. It may have been bad in adolescence and then better. So behavior abnormalities prior to the onset of motor symptoms in adult onset is very common, just like it is in JHD, but it's also nonspecific. I think we're got like one more question.
My granddaughter is in her 4th year of your JHD study.
Mhm. I thank you for that very much.
She has the outburst. It's like a switch, and she gets so angry, her whole body shake. You know, she grits her teeth, and she'll scream at the top of her lungs, and it can last 5 minutes, and then it's, you know, oh, I love you, Nana. You know, so I've learned just to let her go. I mean, she just screams and gets it out, and then she's done with it.
Yeah,
And she acts like nothing ever happened.
right,
In the meantime, I'm going,
right.
but she acts like it never happened at all. And
Right.
I don't even know if she realized that.
Right. And so, yeah, so the description is that of what we were talking about with the aggression, where it just comes on so suddenly, it's so severe, screaming at the top of her lungs.
It could be something minor.
Yeah, something minor, or something that you can't even figure out that what made them mad at, you
See
know.
her walking around, she's smiling and
Right.
saying hello to everybody.
Right.
But that's
Right.
not the way she's at home.
Right. And then that rage also will have a quick offset. And it's also real common afterwards for the patient to say, oh, wow, sorry about that. They certainly have a sense of not being in control of that. And so it is, like I said, I liken it very much to seizures because quick onset, they don't have control. You can't intervene, just like you said. You can't intervene. And the most important thing is just keeping them safe, right? Watching them, keeping them safe, and wait until it's over.
Yeah.
Okay, you know, there's one more question.
Comment. Having been one who my wife accused of just yelling at her about a whole bunch of things. You know, all of a sudden, she had a habit of, she'd come in and she'd chastise me for something. Well, I wouldn't say anything because of the still eventually learn. And that went on for a long time. It still goes on, but at least, but she didn't realize that part of it was also that I knew that the thing I was doing was something that was irritating to her, but why are you sleeping at 3 o'clock in the afternoon?
Right,
Type question.
right. Certainly, there's, so,
I didn't know.
yeah.
So, you know, she was unhappy.
Sure.
And I one day just finally got angry about it, and I said
Sure.
so.
Yeah, I understand. So there's a lot of behaviors, yeah, that sometimes are seen by others, but not necessarily others see them the same way. That happens a lot in families. We're going to have to stop because it's 2:15. Thank you so much for your time.